So I just want to start by thanking Karen and Jim and Diane and the whole organizing committee for inviting me to speak at this wonderful day. I don't know about you, but I can just listen to Sherry Manning the whole day. So, what is amazing about what she's saying is that these skills that she talks about are not only skills that we use when we've got someone in our family with borderline personality disorder. As a mom of a 4-year-old, I was hanging on her lips because the emotional storms that I deal with and have been dealing with the last 4 years as she's learning to regulate her own emotions. And all of these skills that Sherry talks about are just so useful for our everyday lives with all our relationships. It's not really borderline specific or anything like that. And that's why it's so amazing to listen to her. We are going to switch gears a little bit now, because what I'm going to talk about is not so much the skills that we use in the context of family environment when there is someone with borderline personality disorder in our family. But what I'm going to talk about is I'm going to present hard data. So there's going to be lots of statistics and lots of numbers on my slides, and I'm going to do my best to bring it to life to you as much as possible. But what I'm going to present data on is the validity of borderline personality disorder in children and adolescents. And why do we need to do that? Why do we need to have this extremely dry talk, research-based talk on a Saturday afternoon? We need to do it because for the longest time, people did not believe that borderline personality disorder exists in children and adolescents. People believed, clinicians believed, professionals believed, parents believed that a child or an adolescent could wake up on their 18th birthday and suddenly have BPD. You guys know differently. You have seen precursors of this early on, and your child did not wake up on their 18th birthday suddenly with BPD. You've known there was something going on way before 18 year of age. However, I'll share with you the story of a teenager that was admitted just a couple of weeks ago to the Harris County Psychiatric Center, and she's in our study. She's a 14-year-old. She was admitted to hospital after the police found her on the I-10 after she had a car crash. She was driving the car. She was driving under the influence of alcohol. And when the police asked her what happened, she said that her boyfriend of 16-year-old left for a party with his friends, not inviting her with, not taking her with. She tried to call him several times by phone. He didn't respond. She texted him 42 times, not 82 times. She texted him 42 times. He did not respond, and at that point she took her mom's car and she drove, got onto the I-10 and she drove to where the party was going to be held, and she was in a car accident. When she told the police that they need to take her to the party, the police said no, and at that point she threatened to kill herself, and they took her to the Harris County Psychiatric Center. So I'm telling you that story also to elucidate this problem of what is normal adolescence and what is not normal adolescence. We have all seen what it's like. We've all been adolescents. It's a period of storm and stress. It's definitely a time when things go a little bit crazy for all of us. So what makes this teenager, this 14-year-old, different from other 14-year-olds that go through some of the same developmental problems? Now, this is a paper, and I'll often, because it's such a research talk, I have often kind of cut and printed for you the actual papers. Anybody who's interested in copies of the full paper, please contact me. Karen's got my email address. You're also welcome to contact me about any of the questions that you may have here. I'll also be talking a lot about measures, and if you want copies of measures of borderline personality disorder in kids, you can also I've put up pictures of these papers and measures as much as possible. So in 2008, Andrew Channon, who's a big borderline researcher in adolescents, published this paper with the title Complex Case Personality Disorder in Adolescents, the Diagnosis That Dare Not Speak Its Name, trying to get at this idea that why is it that we don't believe in borderline personality disorder in adolescents. And I have to tell you, who knows what the DSM-4 is? The DSM, the Diagnostic and Statistic Manual for Mental Disorders. So it's the kind of Bible of psychiatry. It's what we use to diagnose mental disorders in children and adolescents. And the DSM-4, only with the DSM-4 TR in 2000, made it possible to diagnose borderline personality disorder in adolescents, not in children, only in adolescents, so age 12 and up. And the diagnostic criteria is slightly different. You all know there's 9 criteria for borderline personality disorder. The same 9 criteria apply for adolescents, but it only has to be present for 1 year instead of the 2-year period. And that's how, but it's really only in 2000, so we're talking about 12 years that clinicians can diagnose borderline personality disorder. Do clinicians diagnose borderline personality? They don't. So they don't typically do that. In some settings, they are more open to it. They will sometimes talk about borderline traits. Why are they so reluctant? Because of the stigma associated with the disorder. And these conferences are very important to break down that stigma. Once we put it on the table, we can talk about it. We are busy breaking down the stigma. And so I think this process is happening because the counter-argument to labeling a child with borderline personality disorder is that we are missing an important diagnosis that should be treated. If we don't diagnose, then we cannot get appropriate treatment to that adolescent, and we keep treating. So what we typically find here at the Menninger Clinic with patients after they've been to many other settings, they come to the Menninger Clinic and they say, my child has been diagnosed with every disorder under the sun. Finally, someone is saying that he or she's got borderline personality disorder. And so that's typically what happens. We miss the diagnosis, we don't diagnose it, and that's why Andrew Channon talked about the personality of the diagnosis that dare not speak its name. So when do we know that a disorder is valid? And this is 1970 that Robbins and Goose are 2 psychiatrists who published this paper in the American Journal of Psychiatry and lay down these 5 criteria that I teach my students at UH as well, as how do we know a disorder is valid? What are the criteria that need to be met to say that this is a clinical disorder? And the first thing is clinical description. If you think about a cold, you have to have a runny nose, you have to have a scratchy throat, you have to have teary eyes. If all of those clinical symptoms come together, you can call it a cold. If you have fever, are you going to call it cold? No, you're going to call it flu. So that's exactly the same here. We have to have a clinical description. So we've got our 9 criteria. Can we apply those 9 criteria to kids? That's the first question. Number 2, lab studies. So if we want to know how is cancer different from diabetes, we can look at the body, we can look at the physiology, and we can find differential correlates for those 2 illnesses. In the same way, we have to be able to say BPD is different from depression, is different from anxiety. That's the second way that we know a disorder exists. Then we have to be able to distinguish it from other disorders. We have to be able to say, this is why it's different from depression and anxiety, and this is why it deserves its own diagnosis. Number 4, we have to be able to do follow-up studies. If I have flu today and a cold tomorrow and diabetes next week, we're probably not talking about the same disorder. We're talking about 3 different disorders. So the symptoms must have continuity over time for it to be called a disorder. And finally, family studies. We need to see a genetic basis of the biological phenomenon in the disorder. So these are 5 criteria. In my laboratory at University of Houston, we've been focusing the last 4 years on these two criteria. And so what I'm going to present to you today is some data from that work that we've been doing. Other people have been looking at the other criteria as well, and I'll come back another time and talk about what other people are doing. Today I'm just going to focus on those 2 aspects, the clinical description in adolescents and then the lab studies. In talking about the lab studies, I'll do another, so in talking about the first one, which is the clinical description, I'll share with you a lot of the measures that have been developed to identify borderline in kids. And in talking about the second one, the lab studies, I'll talk a lot about the developmental models that have been developed and validated for how does BPD develop. What are the precursors that we need to look out for as BPD develop in children and adolescents. All right. So before I go on, none of the work that I'll present today would be possible without this place, the place where we're sitting right now. the Menninger Clinic. So in 2008, we started collecting data on all of the kids that get admitted to the adolescent treatment program at the Menninger Clinic, if their parents consented. And we have found that by and large, about a third of the teenagers meet criteria for BPD. So on a diagnostic interview-based measure, they meet criteria for BPD. This is a team, this is just the students that work with me at University of Houston, and then we've benefited greatly from the consultation of Peter Fonagy, who's there on the left-hand side, and you may know, I think John Allen presented this morning on mentalizing. Peter Fonagy is one of the spearhead behind mentalization-based therapy. Liz Newland is the director of the clinic, the ATP clinic, and then Chris Free is our director of research here at the Menninger Clinic. That kind of makes possible that we can do all this research at the Menninger Clinic. So just a thank you to all of these people that have been helping. So I'm going to start off actually not with Menninger data, but with a large data set that was collected in England. And I'm going to talk about the 9 DSM criteria in 11-year-olds. So these are 10 to 11-year-olds, who's pre-adolescent children. And what do we see when we ask children directly about criteria of BPD? So what this study was about, we wanted to evaluate the dimensional structure of BPD. Now, when you go to the doctor and you ask the doctor whether you've got a scratchy throat and you've got teary eyes and you're coughing, and then the doctor's going to tell you you've got a cold or you don't have a cold. Psychiatric disorder doesn't work like that. We don't have BPD or not BPD. We lie somewhere on a continuum of having more or less BPD. All of us have a little bit of BPD, but some of us has more BPD than other BPD. The DSM-5, the edition of the DSM-5 that's going to, the DSM that's going to come out next year, has been trying to build in this dimensional approach in a much more explicit ways, in acknowledgement that you don't have depression or not depression, BPD, not BPD. All of us feel low mood at some point in time. So here we wanted to see, does this dimensional structure, the fact that BPD lies on a continuum, hold for kids? And is it true in kids? The other question we wanted to answer was, are there subtypes of BPD in kids? Or does BPD hang together in kids? Remember, we're trying to validate the disorder of BPD. We have to show that it hangs together as a disorder, that all of these symptoms come together in one syndrome. We also wanted to look at some of the criterion and how each of the criterion function. Are there criterion, are the 9 criterion, that discriminates better, that tells us more whether someone has BPD or not? Or do all the criteria do equally well? And then finally, what about boys and girls? So we used a fancy statistical technique called the differential item functioning, and we wanted to say, are boys and girls different? You guys know that BPD, traditionally, we have thought that the prevalence for BPD is higher in women than in men. Now studies are coming out suggesting that this was really a function of who comes to the clinic. Women report their problems more, and therefore it appeared as if women had BPD more than men. Actually, that seems not to be the case. But what about kids? Do certain BPD criteria distinguish better for girls compared to boys? So this is what we did. This is a wonderful sample. It's 7,149 children attended an 11-year-old outpatient clinic in the United Kingdom. So 6,409 kids were evaluated with Mary Zanarini's child interview for borderline personality disorder. And I will show you example questions of that measure. And again, if you want a copy of the measure, please let me know. So this was about 50 boys and girls. They were mostly Caucasian. They were 11.75 years. This is interesting. BPD was diagnosed on this measure in 0.66% of the kids. Now you know, or you may have heard this prevalence rate. For adults, it's about 1 to 2%. There was a recent study that came out with about 6%. Some people have called into question that prevalence rate for adult BPD. So you can see in this 11-year-old age range, for kids who were above the 5 criteria that you need to have BPD, only 0.66%. However, as you will see in the dimensional data, it doesn't mean that there's no variation. A lot of these kids are on their way to BPD. They just don't meet that 5-point criterion level. So it's very important that we take this dimensional approach, because otherwise if we're just going to go 0-1, you've got it or you don't, then we're going to miss some of those kids. All right, and this is just a lot of data, and typically if you're interested in the statistical class, all those numbers on the right-hand side, you can see they're 0.9 and up, and all that means is that when we fit a one-factor model, in other words, do all the symptoms hang together? They do. So in other words, BPD, even at this low prevalence rate, can come together in one syndrome in 11-year-old kids. And that's an important finding, because if a one-factor model didn't fit, it would mean that these symptoms don't hang together in 11-year-olds. We cannot actually say that there's a coherent disorder that could be present in 11-year-olds. This data says that compared to a model where we have 2 factors and a model where we have 3 factors, the one-factor model wins out. So it really does come together in one coherent disorder. In terms of the dimensionality, for boys and girls, it looked very similar. That's the other important finding. It doesn't hang together better for boys or hang together better for girls. That's also an important finding, because people would say, well, it's something that you can diagnose in girls. They're more mature, they're kind of 2 years ahead compared to boys. That's not the case. It can hang together in a similar fashion for boys and for girls. Also, when we look at, when we put all this data together, it supports this idea that we should move towards a dimensional model of psychiatry, also for borderline personality disorder. So that's all that we're trying to say here. When we look at discrimination, whether there was one criterion or more than one criterion that discriminated better between kids, often people think about self-harm. People would say self-harm is the criterion that you need to look for BPD. If they self-harm, they are borderline. Would you agree with that statement? If they self-harm, they are borderline?
No.
No. There are a lot of people that self-harm that are not borderline. There are a lot of kids that self-harm. We just heard from Sherry, 75% did she say of students. So, so here, what we did here was we just look at some of these criterion and how they did on the thresholds and their discrimination. That just explains to you what each of those things mean. What we found was there was distinction between boys and girls for abandonment fears and impulsivity. Boys were more likely than girls to be rated with uncontrolled anger, suicidal behaviors, and impulsivity. Girls were rated more highly on abandonment fears. Unstable relationships was more discriminating for boys than for girls. Now this makes a lot of sense if we think about what are the problems that girls usually have. It's usually more in the relational domain. What are the problems that boys usually have? It's more in the behavioral domain and the impulsivity domain. So if we are worried about a 11-year-old and we're thinking there might be borderline going on, if it's a boy, what we're going to see is a lot more externalizing behavior. We're going to see conduct problems. We're going to see impulsivity. If it's a girl, we're going to see internalizing behavior. We're going to see worries about relationship, worries about self-worth, and so forth. What happens over time with the externalizing and the internalizing from your experience? What happens over time with externalizing and internalizing? If we say boys are externalizing and girl BPD is internalizing, what happens over time by the time they get to 25? Both. The factor analytic studies for borderline personality disorder shows, if we take all data on psychopathology and we put it into a factor analysis, what's spit out at the end is there's externalizing disorders and there are internalizing disorders. Where do the two meet? In borderline personality disorder. It is a unique disorder in the DSM because it has both externalizing and internalizing. Substance use is externalizing. Depression and anxiety is internalizing. Borderline patients experience both. That's why it's such a complex disorder to treat. Developmentally then, we see for boys and girls a crystallization according to externalizing and internalizing according to our data. So the borderline boy is going to be more externalizing, the borderline girl is going to be more internalizing. As they grow older, these are going to merge and they're going to lie right there between externalizing and internalizing. But these differential criteria washes out at the level of the full test. Just a graph to show that these are, one line is boys and one line is girls, and you can see in terms of BPD liability, the full disorder, there's no difference between boys and girls. So if you put all the criterion together, there's no differentiation for boys and girls. If you look at them separately, then you see differentiation for boys and girls. Diagnostic efficiency, what we found in the 11-year-olds, each criteria didn't do very well in diagnosing borderline personality disorder. So separate, there's no one criteria that you can use to diagnose borderline personality disorder. So they had low values in terms of predicted validity. But as a whole, when you put the disorder together, you could reliably pick out children who met criteria. All right. So now we move on to the borderline personality disorder features scale. So this first paper was just on the 9 criteria. Now we're moving on to a questionnaire-based measure. I'm going to show you what this one looks like. I'm a pretty happy person, not at all true to always true. There's 24 items, so I'm just showing you the first 5. I feel very lonely. Now, if you think about the criteria, this was developed by Nikki Crick in 2005. She published it. It was based on the personality inventory that Les Morey developed. He's a Texas A&M, a personality disorder researcher. And so Nikki Crick took those items from the borderline subscale and she made them child-friendly. And so you can see abandonment and I feel lonely. I'm a pretty happy person, affective instability. I get upset when my parents or friends leave town for a few days. I do things that other people consider wild or out of control. I feel pretty much the same way all the time. My feelings don't change very often. So can we reliably pick out borderline personality disorder from the scale? So in this study, we looked at, do parents and kids agree on borderline personality disorder symptoms? Investigate the criterion validity. So does this measure pick out something that should be relating to other measures in the same way? And we did this in boys precisely because there's no data on boys, where the studies that have been published often focus on girls. So these are community kids, 171 kids, and this very diverse sample from Houston. And this just shows you the correlations between kids and parents. It is, so what you want to look at here on the right-hand side, you see child and parent, the child BPFS and the parent BPFS, and how it relates to all the different measures that we took. At the very bottom here, I'll just show you here, you can see that the correlation between child and parent is 0.21. It's significant, but a full correlation is 1. So from 21 to 1. There is not much overlap between parents and children. When we look at the other correlations, what we came away with using this measure is if you have only 10 minutes and you have to either give a questionnaire to the parents or you have to give a questionnaire to the teen, who should you give it to? To the teen. Why? Because of the strong internalizing components of BPD. When we're asking about conduct disorder and oppositional defiant disorder, you can give a questionnaire to a parent. But because of the internalizing features of BPD, the parents don't know. And you may think back to when your child was 11 or 12. There's a lot of stuff you just did not know. And you had to wait for the behavior to come out to really know what was going on. But there was a lot of stuff going on beforehand that you were not aware of. And so this is what our data showed. If you're in a research setting or in a clinical setting, you have to choose either parent or child measure. For adolescents, you have to go for the teenager measure. It never hurts to get a parent measure as well, but it's not as rich in information as the teenagers themselves. This just shows in terms of correlations with external measures that the child measure does better. All right, so modest but significant agreement between parents and children, similar to most studies for internalizing disorders. Teens themselves report significantly higher means of BPD compared to their parents. Their parents are missing it right now. It'll take time for them to catch up. Cross-method analysis shows strong relationship with externalizing behavior because it was a boys sample. So because it was boys, again, borderline expressed itself more in terms of externalizing behavior than internalizing behavior. Next study, we took this scale and now we want to see, does it correlate with clinician diagnosis and with interview-based diagnosis? So a lot of people say that we shouldn't be using questionnaire measures to diagnose because it just is too fickle. You need a clinician, you need someone to clarify those questions. If you ask a kid, You know, do you feel angry? If you ask a teenager, do you feel angry a lot of the time? What do you think most teenagers will say? Yes, they do feel angry a lot of the time. Now you need to start getting examples of why they feel angry. Do they get angry? Is the anger response from an objective standpoint too big for the event that happened? What is the relationship between the reactivity compared to the event? Do they feel angry most of the time? How severely do they express their anger? Do they get a lot of physical fights? Do they have a lot of fights? Or are they just kind of brewing inside? So until you have a clinician or an interview, you cannot determine whether this... So that's the criticism against questionnaire-based measures. Questionnaire-based measures, on the other hand, are easy to administer, and they're cheap. So here we try to see how does this BPFS that we just looked at in the previous study correlate with a standardized interview. And this was just a sample. It was the same sample that we used earlier, the boys and the girls. And this is what you see, parent and child, and you see this one again. Here is the child. The closer it gets to this corner, the better it matches with the interview-based measure, and you can see the child one does better again. So again, we get more evidence that asking the teenagers themselves about their problems gives us more information, but that both are predictive of the interview-based measure. So if people ask me, should we be using questionnaire-based measures, should we be using interview-based measures, I'll say both. If you don't have time, then the interview-based measure will be okay. But you can't make big decisions on that. You can't make policy decisions on that, and you can't make treatment decisions on that. You really need to wait for clinical interview or standardized interview in order to make those kind of decisions. But it is predictive. That's what we want to show there. We determined a cutoff point. So if you are, I try to get money for a grant where they would screen BPD in all psychiatric acute facilities. And we use this cutoff point here. We didn't get the grant, by the way. But we use this cutoff point. We determined a cutoff point so that it could be a screening measure. So there's a cutoff point on this measure that people can use. So next, we went to the interview-based measure, Mary Zanarini's interview-based measure, and we wanted to work out, is this a good interview-based measure? The measure's never been validated. Does it actually pick up BPD or not? And here's Mary Zanarini's measure then. It goes something like this. This is just the first question. Before we begin, I want to point out that the questions in this interview concern the past 2 years of your life. So she breaks away from the DSM criteria for 1 year, and she makes it 2 years to make the threshold higher. Since you were in that age and that grade, because with kids you have to kind of be concrete about time, even with teenagers, I also want to point out that I'm mainly interested in learning about feelings, thoughts and behaviors that have been typical for you during the past 2 years. I teach the people that do the interviews for our studies to also say what's typical for your personality. So we just put that word out there so that teens understand we're talking about me as a person, not just how I was one day, three months ago when I was very upset. However, I will also be asking you a number of questions about specific things that you may have done only when you were particularly upset. And then it goes like this. In the past 2 years, have you felt very angry a lot of the time? And then you'll see there are several questions that get at the same stem. And the stem is in bold down there. Inappropriate, intense anger or difficulty controlling anger. That's the DSM criteria. Frequent displays of temper, constant anger, recurrent physical fights. And then the interviewer will rate this 2, 1 or 0 based on the quality of the examples. So it's an interview-based assessment. The interviewer has to be trained, the interviewer has to understand borderline personality disorder in order to give an accurate rating of 2, 1 or 0. And so here we wanted to look at the internal construct validity, inter-rater reliability. If 2 people do it, do they agree with each other? We wanted to look at, does it agree with other measures of borderline personality disorder? And we wanted to look at it both from a categorical point of view and a dimensional point of view. We did this in 190 kids here at the Menninger Clinic. And we did find again the one-factor model was supported. So again, BPD hangs together as one disorder. This is very important for the field because people have thought about BPD standing on several legs. There's more and more data now coming out saying that it's one coherent disorder. So that was important, that this is also true for kids. So we want to see the continuity in the results between kids and adults. That validates the disorder in kids. And there you can see just all of the different the 9 criteria, and we see that all of them contribute to the disorder. One, again, is full marks, as it were. You can see 79, 75, 74, 74, 67, 62. You can see chronic emptiness contributes the least. When we find, when we talk with teens, many of them don't know what we mean when we say, do you often feel empty? Other teens give us beautiful answers. They say, yes, I often do feel empty. It's like a big pit that I can't fill. It's a void. It's just a black hole. Some of the teens can actually describe that, but many of the teens just don't know what it is, and then they have comorbid depression. So they can't distinguish yet between emptiness and hopelessness. I think even for adults, it's sometimes difficult to distinguish between emptiness and hopelessness. So that is why that criterion is not doing very well. Transient paranoid ideation does not do very well either. Many of them have not gotten to the point where they mistrust to the degree that adult borderline patients do. Criterion validity, good overlap with clinician diagnosis. And then all of the other borderline measures that we included that are more established. The CIBPD came out in 2003. Mary Zanarini published one, which she actually didn't publish a paper, but she published a test in 2003. And so this was important validity data to say that clinicians can use this measure in their clinical practice to diagnose BPD in kids. Criterion validity, same thing. It also correlated with emotion dysregulation, as you would expect it should. So all the external validity worked out. I'm not going to go through all of these in detail. Finally, so you can do the BPFSC, which is dimensional measure of BPD. You can do the CIBPD, which is an interview-based measure of BPD. And finally, we validated the MSI, which is 10 questions, yes, no. You can do it over the phone in 5 minutes. So this is a screener. That's what we call a screener. So in this study, we just wanted to screen for BPD. We did this at HCPC here in Houston. And I'll just show you the graph again. You can see the one that you're getting to know by now. If it gets into that corner, then the MSI is doing well in picking out BPD, kids with BPD. And so the take-home message in terms of, can one accurately assess and identify BPD in adolescents? And the answer is yes. So I'm going to move on to the second question. How does one understand the development or early precursors of BPD in children and adolescents? And this is where our lab studies come in that we've been doing. Before I go on, any questions about that first very dry? Thank you for hanging in there, yes. That was also low, and the reason is because a lot of kids are impulsive. So there's many ways in which you can get a low rating, and it's again not discriminatory. A lot of teenagers are so either they don't know what it means and it doesn't do well, or a lot of them do it and it just doesn't tell you anything about the disorder. Good question. Any more questions about this piece? Yes.
Can you describe the difference between the hopelessness and
the emptiness
really quick?
What we typically do when we interview is we say, this thing that you feel, which you talk about as emptiness, does it come and go with depression, or is it more stable for you? Is it more chronic? So that's one way, and then they will say, actually it's just only when I feel depressed that I feel empty, because emptiness typically is more nihilistic, it's existential, and it should be more of a personality trait than something that comes and goes with depression.
That's what I was wondering, if you were getting to the more, I don't know who I am or why I'm here.
That's the first way. The second way is definitely a qualitative difference. The hopelessness is really about the future and about feeling that the cognition, I can't. What my daughter keeps telling me, it's I can't, and then I say, no, it's Mama says I can't, and then she says, it's I can. So that cognition of hopelessness is really about I can't, and but emptiness is existential. It's a sense, and people with BPD in the audience can help me here, but it's a sense of that no matter what you do, there's an emptiness that cannot be filled. There's a feeling of spentness, a feeling of that other people can't fill it up for you, and you keep trying, other people can't, your job can't, relationships can't. It's just an existential nihilism around that. Is there anybody with BPD who wants to share more about that? Yeah.
Emptiness. It's like there's this big gaping hole inside of you. It's in your soul, and you go and you search, and you can search the entire world, and it's like nothing you've ever tried. No cutting, no burning, no beating. No amount of boyfriends or friends, no matter how much love you get from some people, it won't fill that. That's something that I've learned through the hard way, that it's something that you have to find for yourself.
Okay, thank you.
If you don't find it soon enough, it'll overtake your entire body.
There you get a cogent description.
Yes.
Thank you so much. That is exactly it. And I think, if you take, it's the hardest thing to describe to people who don't experience it. And usually when we interview kids and adults alike, and there's not a recognition in their eyes that they know it, we assume they don't. And then we try and work out if they acknowledge something akin to it, it's usually hopelessness. But people who've experienced it knows what it feels like and can talk about it. All right, so if there's no questions more about this first part, I'll go on to how do we understand the development and precursors of BPD. And I think John Allen would have given you a taste of this this morning already. Now, one pathway by which we think BPD may be developing is through the interpersonal pathway. So when you hear DBT folks talk, they will say the way that the mechanism by which BPD develops is through emotion. When you hear the mentalization-based folks talk, you will say BPD developed through this interpersonal pathway. They are compatible with each other. The mentalization-based folks talk about emotion just a little bit later, and the DBT folks talk about relationships just a little bit later. So it's where you begin your story that's different for mentalization and for DBT. Both come together in the end because emotion and relationships are both intertwined with one another. But when we do think about BPD, the popular media have noticed this interpersonal dimension of BPD. I don't know if you guys saw Girl Interrupted with Angelina Jolie. She is someone with BPD in the movie. Glenn Close in what was it called? Fatal Attraction. She was considered to have BPD in that movie. There are popular books written with titles such as Stop Walking on Eggshells or I Hate You, Don't Leave Me. All of them trying to get at this interpersonal dimension. It is true that when we go to the data, that the data shows people with BPD have more interpersonal problems. So they have a greater number of breakups, they have impairment in their social relationships, they report lower marital satisfaction, and in prospective studies with kids, the big child in the community study, they also showed that kids who have borderline traits in adolescence have more breakups later in life. And in Nikki Crick's study in kids, which was also a longitudinal study, she showed that in their relationships with peers, they often have hostile attributional biases. So when they're in a peer relationship, they would often think another kid is out to get them, although that kid wasn't necessarily out to get them. So a little bit of the paranoia that we would talk about in adulthood You will see this hostile attributional bias in kids. And then enmeshment with best friends. So a real requirement of loyalty from best friends, and hurt feelings when a best friend would break that loyalty. So this is what people have found. Very little data, as you can see, just on what do interpersonal relationships look like in kids with BPD, but certainly in adults there seems to be some data to suggest that people with BPD do have interpersonal problems. I think some of you may also testify to how difficult some of the relationships have been with a loved one with BPD. When we look at the DSM criteria, 8 of the 9 criteria happens in an interpersonal context. Frantic efforts to avoid real or imagined abandonment. So abandonment is interpersonal. The pattern of unstable and intense relationships, that's interpersonal. Identity disturbance, most often in situations in which the person feels a lack of meaningful relationships, nurturing or support. So then trying to fit with, if I change myself like this, would I fit in? If I change myself like that, would I be loved? Or would I get the love that I feel that I need? So the identity disturbance happens also in the context of interpersonal relationships. The impulsivity often happens in interpersonal contexts, unsafe sex, anger outbursts. The suicidal behaviors are often precipitated by threats of separation or rejection, so also interpersonal. The active instability is often in the context of interpersonal stresses. And then finally, the anger often elicited with the caregiver or lover is seen as neglectful, withholding, uncaring, or abandonment. So also from the DSM perspective, which I would consider the most unimaginative way of thinking about BPD, even there we see this very strong interpersonal flavor coming through. So if BPD is by its very nature interpersonal, how do we begin to unpack its development? And this is Peter Fonagy's theory of BPD, and this was a very helpful picture that him and Patrick Leighton developed. They published that in 2009 in a big child psychiatry journal. And they describe these distal and proximal factors for the development of BPD. And on this side, you see the distal factors over here. Distal meaning long ago, the proximal factors over here. And on this side, you see the BPD core features. So I'm just going to unpack that a little bit for you. So the distal factors are two things: constitutional factors, and Marsha Linehan talks about this too. Emotional vulnerability. So you are born with being sensitive. That's why a lot of people with BPD are wonderful writers, why they can connect very well with other people, why many studies have shown superior social cognitive ability. They have senses for social situations, they pick up stuff very easily. They are in many ways very, very skilled because of the sensitivity. Now the sensitivity at the same time makes them very vulnerable. Thin-skinned people. Combined with an early caregiving context. Now as a mom, I know how hard it is to regulate my daughter's emotions, and she's a firecracker with strong emotions, and I am her prefrontal cortex and have been her prefrontal cortex for the last 4 years, and I'm exhausted. And so it is very, very hard work when you have a child with strong emotions and high sensitivity to provide the right caregiving experience. Very hard. So when you put this emotional vulnerability together with high demands on the caregiving experience, you may find attachment disruptions. I know Ephraim Bleiberg, Ellen's husband, has often used this example of the mom where the baby cries, and what she does is she opens the bath water so that she can't hear the baby, because she herself is overwhelmed. Remember how Sherry talked about regulate your own emotion. There is nothing like sleep deprivation, nothing like being tired yourself, feeling incompetent as a parent. You've never done this before. People say you should be doing breastfeeding, you should be doing this, you should be doing that, you should be that. In the meantime, your husband's struggling with parenthood. He has not done it before either. and you've got financial problems, you're still both trying to do your jobs, and you open the bathwater when the baby cries. That is how the attachment disruption, you just doing your best to stay afloat, and you've got this very, very sensitive baby who needs you, and you just cannot give anymore. And so this attachment disruption occurs. Peter Fonagy says that's what's necessary for attachment to happen beyond the mom being present, the dad being present. We forget about dads. Our data at the Mania Clinic shows dads are very, very important. But what happens often, or what you need for attachment to occur, is what Peter Fonagy calls contingent mirroring. So the baby will cry, or the infant will cry, and the mom or the dad will mark the emotion, validate the emotion in DBT language. They'll validate the emotion, but regulate it at the same time. Validating the infant's emotion is not going to go, ah, when the baby cries. That's not validating the emotion. Validating the emotion is, oh, I can see you are sad. I can see you are sad, but I'm regulating it already by not going, ah. If I go, ah, I'm kind of mirroring it, but it's not marked mirroring because I didn't tweak it. I did not regulate it. I didn't use my prefrontal cortex to regulate the infant's amygdala. So it's kind of, I always think we, as parents, we have to have this capacity to take our brains into the brains of our kids and help them with that affective storm, that emotional storm that they have. So this is extremely hard to do. This is extremely hard to do for everybody. And when you've got a specifically sensitive child, and you have perhaps your own constitution, perhaps you're someone yourself that finds it hard to regulate your emotions, and now you have to do double duty. And so it becomes a very hard problem, and you get an attachment disruption. Now, what happens when you have attachment disruption? Attachment is there to help us learn, this is me, and that is you. That's what attachment teaches us. It teaches me that I am a child that is taking my cues from my mom, but I may also have different intentions and different needs as my mom. And so that's what attachment teaches us, and when attachment doesn't occur, self and other does not differentiate the way it should. The child gets confused as to who am I and who's my mom. And they start being hyper. Remember, mom was going, ah, when I cried. So now I start being hyper vigilant to mom's emotions. And I'm starting to be confused about, if mom is upset, is it me who's upset? I need to be upset, because if mom is upset, I will get upset. Can you see there's a confusion that starts to happen between mom and me? That confusion, Marla used to talk about differentiation of self, but there's poor self-differentiation. This leads to hypersensitivity to mental state. I've started calling this hypermentalizing, and I'll show you an example of a task that taps into hypermentalizing. So for the longest time, people have thought the interpersonal problems associated with BPD is due to a lack of mentalizing. However, more and more data came out that showed borderline patients have superior mentalizing capacity. They're very good at mentalizing. If you show borderline patients a face that morphs from neutral into an emotion like anger or anything, the borderline patients compared to healthy controls will pick out the change in the emotion much quicker than the healthy controls. Superior ability. Why? Because they've had to learn at a very young age to be super sensitive, because this is a high stake environment. This is an intense emotional environment, because my emotions, which just come because I'm an infant, is met with high emotion. It's not met with calm, it's met with high emotion. So emotion is, can you see how we're moving into DBT territory? So it starts with the attachment relationship, but moves into the DBT territory. So hypersensitivity to mental states, and a low threshold for attachment activation. So in most cases, people with with borderline personality disorder, well, this hypersensitivity to mental states are okay. It helps in many cases. But when you're in an attachment situation, doing too much of this good thing can get you into trouble. So the best way I can explain hypermentalizing would be, for instance, to think of, say, Ellen and I wanted to go to dinner, and we had an appointment to go to dinner tonight, and at the last minute I call her and I say, Ellen, I am sorry, but I can't make it, something's come up. Now, Ellen would be hypermentalizing if she then thinks to herself, yeah, I think it's because that one time when Carla and I were to meet for lunch in Rice Village, I didn't turn up, and she is now punishing me for that time. She doesn't really have something going on, but she's punishing me at the last minute. She's messing up my plans. That's an example of hypermentalizing. The psychoanalysts used to talk about projective identification. Can you see how there is a mixture of her mind with my mind? She is projecting her own thoughts into my mind. Self and other differentiation based on a mix-up very early on about self-other differentiation. So when we're in an attachment context, this is not going to be helpful, because what will Ellen do next? She'll call me up and say, fuck you. And I will be like, what? Where does that come from? Now, if I were to be able to go back and say, Ellen, what the hell happened? Then we can start unpack this. But if I could easily walk away and we have a disruption in our friendship. So you can see what's going to happen when you're hypermentalized. And so when we're in an attachment context, we are especially vulnerable for this hypermentalizing to occur, and this is going to dysregulate our emotions. When she feels I have let her down on purpose because of this thing that happened 6 months ago, then she is going to feel emotionally dysregulated. So you can see where DBT is going to come into the picture. And then we get all the borderline features here. So this is stress and arousal. You guys know all of us do poorer on everything when we're stressed. Mentalizing is no different. When we are stressed out, we do poorer on mentalization. So this is the model that Peter developed, and up until very recently, there's been no data on this, even in adults, but especially in adolescents. So what we've done over the last 4 years is trying to systematically test pieces of this model, because until the data is there, we can't really say that it really exists or this model means something. There's been a lot of studies in adults that have linked attachment disruption to borderline features. So that is no news, but no studies in teens that connects attachment with BPD features in teens. So that was our first aim. Our second aim was to look at this hypermentalizing, and what we did, I'm going to scoot forward just to show you the task so that you have a good understanding of this. So what we do with the teenagers, we show them this movie task that was developed by someone in Germany. And the teens see this as a movie. What I've done, because I'm worried about technology, is just take out some of the clips so that you can get a sense of how the task works. And you can all participate if you feel brave. So we will say, for instance, you will be watching a 15-minute film. Please watch very carefully and try to understand what each character is thinking or feeling. You'll meet each character, Sandra, Betty, Cliff, and Michael. And then the film clip starts, and I've just given you the narrative. Of course, they'll just watch this without any words, without any narrative. A young, attractive woman named Sarah opens the front door. Upon opening, a man who looks to be around the same age as Sarah enters the house. Before she can answer or say hello, anything like that, he tells her that she looks terrific. He asks whether she did something with her hair. Sandra touches her hair and starts to say something, but the young man compliments her by telling her that her hair looks very classy. So there's a bit of information beforehand in the movie clip that she's got the hots for someone else actually, and this guy has got the hots for her. And so that's the kind of context of the thing. And now that we stop the movie and we ask the teenager, what is Sandra feeling? Her hair does not look that nice. She's pleased about his compliment. She's exasperated about Michael coming on too strong. She's flattered but somewhat taken by surprise. I won't embarrass anybody by asking you to choose. But the hypermentalizing response is C. She's not exasperated. She may be down the line, but that's going beyond the data. It's very subtle. The correct response is she's flattered, but somewhat taken by surprise. Her hair does not look that nice is a no mentalizing response. She doesn't make use of the mind at all to interpret what's going on. That autistic people would choose that one. She's pleased about his compliment. I think my husband would choose that one. It's under-mentalizing. Almost there, but just not quite there. Trying, but not quite getting it. So, but here you go. She's exasperated about Michael coming on too strong. The borderline teens in our unit choose that one. Depressed people don't choose that one. Conduct disordered kids don't choose that one. So we're really seeing something that's specific to borderline personality disorder, hypermentalizing. And so what we just did in this study, I know my time's coming to an end, what we did was we did attachment interviews with all our teens. It's the child attachment interview. You have to go to London to get training, and then you code it. It's a very laborious interview, but it gives you a sense of the representation, the attachment. Is the kid securely attached? And remember, attachment is just in your head. When I learned that for the first time, I was flabbergasted. We watched a tape of a 10-year-old who is kicked by her dad. She came out as securely attached. You can be kicked by your dad and be securely attached. Is meaning making. Is can you make sense of that experience? That's what secure attachment is. If you can make sense of that experience, you can be securely attached, even though horrible abuse may be going on. Insecure attachment is you can't make sense of it. You either dismiss it, you push it away, or you are constantly busy with it in your head. What do you think borderline patients, which style do they mostly engage in? Constantly busy with it in their head. They're preoccupied. They can't move away from the attachment. Constantly checking. Do you still love me? Why don't you love me? Why are you not loving me? Why are you not showing me that you love me? I'm angry at you. Actually, I love you. So it's a constant busy, preoccupied with that attachment. So we give this attachment interview to the kids. We give them the mentalizing task. And then we look at the borderline features. And what we found was that attachment predicts hypermentalizing and predicts borderline features, not emotion dysregulation. So what that tells us is that you need to focus on the hypermentalizing before you focus on the emotion dysregulation. More data is necessary sequentially. Remember, this is cross-sectional. So it's all, we measure it all at the same time. We don't measure the one and then the other and then the other in a process type. But our data so far suggests you have to focus on the bring the hypermentalizing down and then address the emotion dysregulation. So this is open for debate. It's a discussion. All right, so just this is an important study. That's all that that slide says. And what I would say is that the mentalizing deficits that we've typically in the old days thought about to be associated with BPD are probably not there. But when you combine problems in the interpersonal domain with emotion dysregulation, what you get is hypermentalizing. So I would say that that, for me, is becoming the most distinguishing feature. And the thing that we need to address in teenagers in order to help them get better. So that was the second question I wanted to talk about. And just getting back to our original question then, there really is validity for this disorder in adolescents. You can measure it reliably. And we can also start looking at some of these early precursors to developmental pathway in this. And we do this, of course. I envy people like Sherry Manning because I am not on this side, the recovery side of BPD, but I'm so glad that there are such wonderful, competent people on the recovery side of BPD to pick up what we do on the other side and bring that into the recovery process. So thank you very much for the time and your attention.